So we are going to finish off with our last section here, our last chronic neuromuscular disorder with head injuries. Now we're going to spend a whole lot more time with head injuries when we start talking about our trauma patients, but this is a good overview for us to get an understanding and a start to understanding head injuries. So sometimes these patients are called a traumatic brain injury, and that is, according to the CDC, contributes to about 30% of all deaths in the United States. Falls are typically the highest incidence of traumatic brain injuries, and a lot of times these brain injuries can result in multiple respiratory complications. And a lot of times these head injury patients can result in multiple respiratory complications. Patients with traumatic brain injuries typically exhibit a level of decreased consciousness or a decrease in level of consciousness, which will significantly increase the risk for aspiration. Oftentimes these patients will exhibit apnea secondary to airway obstruction in the setting of decreased or complete loss of consciousness, which increase their risk of aspiration. So when we have these aspiration events in apnea, this leads to hypoxemia and hypercapnia, which further compromise cerebral brain injuries. When you decrease the amount of oxygen that's being delivered to the brain, your risk of the head injury or the brain injury, the cerebral injury, goes up as well. For these patients, we are going to protect their airway. That is the highest level of order when we get these head injury patients. So one of the things that we want to talk about or we want to evaluate, and we talked about it earlier in one of the other sections, is the Glasgow Coma Scale, or the GCS. If that GCS is less than 8, we're going to intubate, right? And we will delve into all of the different contributing factors to the GCS when we go into those trauma patients. So when we look at these head trauma patients or the traumatic brain injury patients or the head injury patients, we want to do a thorough assessment, including the maxillofacial or spinal cord traumas. So when we are going through our thorough assessment, we want to make sure that we focus on any maxillofacial injuries or spinal cord injuries, because these could lead to an increased need for that protective airway or airway management. When we have these head injury patients, we want to do everything that we can, because there's an increased risk of patients that develop hypoxemia, cardiac arrest, hypocapnia, and hemodynamic instability. We want to do everything that we can to prevent these things from happening, because the mortality and the morbidity rates increase when we have hypoxemia, cardiac arrest, hypocapnia, and hemodynamic instability. And the book talks about this incidence where we want to make sure that we're preventing and fighting and making sure that we're paying special attention to these things within the next 60 minutes after intubation. The likelihood goes up within those first 60 minutes. Once we get that patient stabilized, we can start to kind of exhale a little bit and catch our breath from these traumatic brain injuries. Things that we want to make sure that we're doing: we want to do a jaw thrust. We don't necessarily want to do a head tilt, because we can clamp off the spinal cord. If there are spinal cord injuries, we want to make sure that that head stays in a neutral position, and we can do a jaw thrust to open up the airway when we are bag mask ventilating. We can use a supraglottic airway, like an LMA or a King tube, that we could use for life-saving emergent situations before we place an endotracheal tube. If we can get a LMA in place and then pass a bougie, then we can get the LMA out and pass an ET tube for long-term mechanical ventilation. So when we intubate these patients, a lot of times we're going to use what's called a rapid sequence intubation. That means that we're going to hyperoxygenate these patients, get them the sedatives and the paralytics that they need quickly so that we can establish an airway. But a lot of times it's really not uncommon for the patients to actually develop hypotension as well when we have head injuries, especially when we give them sedatives and allow their body to relax. They no longer have that tension, and the vasculature will relax as well, causing hypoventilation. And also remember, positive pressure ventilation, that's bagging, that's the ventilator, all of those will also reduce the venous return, decreasing the blood pressure as well, causing hypotension. So when we have those patients that are coming in with a head injury, we want to make sure that they or that we are prepared for any of the fluid loss or any of the blood loss that they may have endured or suffered secondary to this injury. So we're going to have packed red blood cells ready and available, and we're going to have IV fluids ready and available when that patient arrives to the emergency department, so that we can make sure that their blood pressure does not fall secondary to the positive pressure and the fluid loss and the induction agents, or the RSI, rapid sequence intubation agents. All of those can be causes of hypotension. Sometimes we have these patients and we're going to do what's called an awake intubation. I showed you guys a video of the anesthesiology professor at Harvard who would do awake intubations on himself. Sometimes we do this in the emergency department as well, because when we give those sedatives, it can cause a systemic vasodilation, which will significantly drop the blood pressure, and then we'll end up in a cardiac arrest situation. So we want to make sure that we are doing everything that we possibly can to protect the patient from going into cardiac arrest. So sometimes an awake intubation is the answer in that. I've seen this done a number of times where we give the patient a lidocaine lollipop and we spray the back of the throat with lidocaine, and we use a bronchoscope to direct our path to get to the vocal cords and pass the endotracheal tube through the bronchoscope so that we can secure an airway. These patients oftentimes end up on long-term mechanical ventilation, so we want to think about tracheostomy early. We don't necessarily want to think about that late. We get a decrease in airway resistance. It's more comfortable. We can do oral care a whole lot better. Lots of benefits for a tracheostomy tube versus an endotracheal tube when it comes to long-term mechanical ventilation. And the last thing that we're going to look at is increased intracranial pressure monitoring. So normal ICP is 5 to 10. Anything that's greater than 20 is going to be critical. We'll talk about in our trauma unit how we actually monitor this and how we treat for increased ICPs. So when we talk about our protocols, we want to make sure that we are oxygenating these patients adequately. They may not have an effective cough, so we're talking about airway clearance. They may not have a cough reflex at all, so we may have to use devices like the insufflator, exsufflator. We may have to use quad cough techniques. These patients may end up on bronchodilators, lung expansion, whether we're using positive pressure with PEEP or encouraging these patients with EZ-PAP or an IS. All of those are going to be working for lung expansion. When we have these patients on mechanical ventilation, we're going to have what's called gentle hyperventilation. We're going to use gentle hyperventilation, meaning we're not going to target a CO2 of 40. We're going to target a CO2 that's a little bit less than 40 at either 30 to 35 centimeters of water. So we're going to target a CO2 of about 30 to 35. What this does is it helps prevent an increase in ICPs. So some of the things that we do, and we'll talk about it a whole lot more in our full-blown head trauma unit, but we will use gentle hyperventilation strategies with mechanical ventilation. Early mobility, we hadn't talked about this yet, but these patients that end up on long-term mechanical ventilation, we don't necessarily want to set ourselves up for having to rehab this patient. Why don't we just go ahead and set this patient up for prehab, we're doing everything that we possibly can to prevent them from needing rehab. So we did it with preventing hypotension and cardiac arrest by giving these patients fluids and blood products. Why don't we treat the entire body the same way and the muscular skeletal system by getting these patients up and walking them early, utilizing physical therapy and preventing muscle wasting from them being in bed for weeks and months on end. Last thing is we're going to be very efficient and effective with our trach care. We've got to make sure that these patients do not get any nosocomial infections, and trach care is part of our responsibility that we need to do to make sure that we are taking care of or preventing any of those nosocomial infections. If we've got a patient that has the gross and the fine motor skills, we can teach them how to do their own trach care. Why not get this patient set up for success for whenever they go to an LTAC or whenever they're discharged home? Sometimes these patients end up with a trach at home. Why wouldn't we go ahead and show them how to do their own trach care and start to care for themselves? We want to keep these patients in a normal environment as much as possible where they are learning how to take care of themselves, because let's say that patient gets discharged to an LTAC or a PAMS facility or even home, and they come back within 60 days with pneumonia because they haven't been cleaning their trach effectively. We're going to have to make sure that we do everything that we possibly can to have any bounce back from these patients. So lots and lots of information when it comes to neuromuscular disorders. We've got Guillain-Barré, we've got myasthenia gravis, we've got the stroke patients, we've got head injuries, spinal cord injuries, we've got the muscular dystrophies. We've got a whole list of neuromuscular disorders, and I didn't hit on all of them, but this is a great start for us to understand what we can do and what we need to do for these patients that end up with long-term neuromuscular disorders.